Hi, y'all. My name is Dalisa, and I'm here with Lisa, Brooke, and Joey, and we'll be talking about the restraints and seclusion for people with autism and other developmental disabilities. A few things that we'll be talking about, including the use of seclusion and restraint as a part of a behavior plan, as well as a last resort. We'll also have some arguments for the use of seclusion. We'll discuss the role of a BCBA when using seclusion and restraints. We'll also go over the procedures to improve training or decreasing the need for seclusion restraints. And then we'll go over, lastly, the arguments against the use of restraints and seclusions. To finalize our debate, we'll go ahead and have some questions and answers at the end. But nonetheless, to have a little briefing of what we'll be going over, we'll go over some definitions that we'll be using as far as terms. Well, certain terms we'll be hearing is restraints. Restraints is the process of the physical holding or securing of an individual. It can be for either a small moment of time for them to stop or interfere with a severe behavior, or it can be for an extended period of time using mechanical devices to stop an uncomfortable severe behavior. For example, self-injurious behaviors that could potentially cause serious injuries to either themselves or others. Something else that you'll be hearing a lot is seclusion. Seclusion is the isolation of an individual from others to stop from others in order to stop or interfere with the severe behavior that could potentially cause harm to either themselves or others. Another thing we'll be hearing is physical restraint. This is the application of bodily force to address aggressive behavior. Mechanical restraint is another term, and this is the use of objects to restrain an individuals, such as straps. Lastly, you'll hear chemical restraint. This is the introduction of medication for an individual in order to control their aggressive behavior. In order to go over the use of seclusion and restraint as a behavior plan, we're going to be going over the use of restraint as a behavior plan, also known as a BIP, which is done to help reduce the probability that a severe behavior can occur as well as the severity of the behavior. The BIP will include the reinforced-based procedures, and this will be based on the functional behavior analysis and will be evaluated with the data, and that is consistent with the research and the best practices in order to use restraint. In reference to using restraint or seclusion for an emergency as a last resort, this is having physical emergency restraint is physically holding a person in order to protect themselves or others from behaviors that can cause harm. It should only be considered for behaviors that are dangerous and unpredictable. The procedures should only be used when less intrusive interventions are not working and when they have been deemed insufficient for the situation. Or lastly, in emergency situations where seclusion or restraint should be involved, weighing the pros and cons of these procedures against any risk associated without using them. Risks of not using appropriate restraints could include the increase for injury, excessive use of medication, and expulsion from school, which or a placement can be more restrictive. Joey is going to be able to discuss with you guys the arguments of the use of restraint and seclusion.
Okay. So in 2010, the Association of Applied Behavior Analysis International, the ABAI, released a policy statement regarding seclusion and restraint. The policy statement indicated that its members strongly oppose the inappropriate or unnecessary use of seclusion and restraint. The ABAI indicated that many individuals with severe behavior problems can be treated without the use of seclusion and restraint, but in some situations, it may be necessary due to the dangerous behavior of the individual. So when creating this policy, the ABAI included 3 guiding principles in their support for the use of seclusion and restraint in certain situations. So the first guiding principle is the welfare of the individual served is the highest priority. So what this is saying is clinical decisions should be made based upon the professional judgment of an informed treatment team that demonstrates knowledge of the research and best practices. The team should determine that any procedure used is in the individual's best interest. So the BCBAs and the rest of the treatment team need to look at the individual client and make a determination if seclusion restraint is appropriate to use. So Code 1.01 of the BACB Professional and Ethical Compliance Code for Behavior Analysts states, behavior analysts rely on professionally derived knowledge based on science and behavior analysis when making scientific or professional judgments in human service population. This code supports the argument that, that clinical decisions should be made using professional judgment to provide treatment that is in the individual's best interest. The second guiding principle is individuals have the right to choose. So, and this includes parents or guardians of the client. So the ABAI supports U.S. Supreme Court rulings that individuals have a right to treatment and that many state and federal regulations and laws create those rights. So a regulation that prohibits treatment that includes the necessary use of restraint violates the individual's rights to effective treatment. So the ABAI stated, the irresponsible use of certain procedures by unqualified or incompetent people should not result in policies that limit the rights of those duly qualified and responsible for an individual through the process of making informed choices. So to not allow seclusion restraint would be infringing on the rights of clients to receive effective treatment if the treatment team determined seclusion restraint would be effective for that client. Code 2.09 of the BACB Professional and Ethical Compliance Code for Behavior Analysts states, clients have the right to effective treatment. Behavior analysts always have the obligation to advocate for and educate the client about scientifically supported, most effective treatment procedures. The BACB Ethical Code supports the argument that individuals have the right to effective treatment. And the third guiding principle is the principle of least restrictiveness. So the ABAI supports the position that the treatment selection should be guided by the principle of least restrictiveness. ABAI defined least restrictive treatment as treatment that affords the most favorable risk to benefit ratio with specific consideration of probability of treatment success, anticipated during of treatment, distress caused by procedures, and distress caused by the behavior itself. So Code 4.09 of the BACB Professional and Ethical Compliance Codes for Behavior Analysts states, behavior analysts always review and appraise the restrictiveness of the procedure and always recommend the least restrictive procedure likely to be effective. The statement went on to say that a non-intrusive intervention that allows dangerous behavior to continue or results in more restrictive placement may be considered more restrictive than an intensive intervention that is effective. What this is saying is that if seclusion restraint is not used in situations where client's behavior is dangerous or likely to cause harm, that behavior may continue without using seclusion restraint, and the behavior episode from the client could possibly cause distress to that client. It could also cause the client to be moved into a different placement that is more restrictive or possibly not receive any therapy at all if there are no providers in the area. So for example, if I work at the only ABA company in a 100-mile radius and we have a client that is engaging in very aggressive and dangerous behavior, and we are not allowed to do seclusion restraint, or we don't use those methods because we feel they are unethical, we may need to discharge that client, then he may not get the therapy or treatment at all. So in my opinion, that would be more unethical and would not be in the client's best interest. So seclusion restraint should only be used under certain situations where the individual is engaging in severe behavior that's imposing immediate risk or harm to the individual or someone else. It is up to the BCBAs or other qualified professionals to determine when it is appropriate to use and for which clients. To deny the use of seclusion restraint in appropriate situations will be denying the rights of individuals and could be considered unethical. So next, we will be hearing from Lisa regarding the roles of the BCBA in seclusion restraint and some procedures to improve training around seclusion restraint.
The role of the BCBA when using seclusion restraint. Different states have different laws pertaining to the use of seclusion or restraint. Everyone should be informed on what their state allows and does not allow when it comes to using them and using one in a behavior plan. First and foremost, the BCBA should be properly trained on how to use seclusion and restraints and what to do in different situations. It should only be used when the safety of the client or others are in jeopardy and all de-escalation techniques have failed. It should only be used for as long as the emergency lasts. BCBAs should have their functional analysis done to see what may be causing the behaviors. Knowing a student's trigger can help with coming up with ways to prevent the behavior from happening, or a way to know when they are escalating. A behavior plan should include reinforcement-based procedures to lessen the likelihood of the need for seclusion and restraints. When putting seclusion and restraints into a behavior plan, it should be written so it goes from least restrictive to most restrictive. The staff who will be implementing the procedures should be well trained not only on how to use them, but on all the steps taken before getting to the point of using them. They must get informed consent. Individuals and parents or guardians must be allowed the opportunity to participate in any behavior plan. Interventions involving seclusion or restraint should only be used when the full consent of those involved with making decisions. The behavioral analysis is responsible for making sure that the highest standard of effective and humane treatment are being followed with any behavior plan utilizing seclusion or restraint. Ensuring procedures using seclusion or restraint are only being implemented by staff who are fully trained in their use. You should be continually monitoring the seclusion or restraint using data to evaluate its effectiveness. And procedures involving seclusion or restraint should only continue if they are safe and effective, and their use should be reduced or eliminated whenever possible. BCBAs need to provide oversight to this process when creating and evaluating behavior plans. Sometimes there is the need that a BCBA has to use emergency restraints that are not part of a behavior plan. They should only be used on students who pose an imminent risk of harm to themselves or others when they're in a dangerous or harmful behavior that occurs at unpredictable times. The procedures should be considered only when less intrusive interventions have been attempted and failed. An emergency restraint should be properly documented, and the parents or guardians should be notified. After a restraint is used, there should be a debriefing after each episode that allows staff members to review the information and plan prevention strategies for future similar situations. The procedures to improve training and decrease the need for seclusion or restraints. CPI training is a nationally used training to teach the correct way to get out of certain situations and how to properly restrain someone if needed. Of course, even though you may practice these techniques, you are not actively using them on clients who are in a behavior or a dangerous situation, and you should be cautious of that at all times. CPI trains staff not only on using different techniques for seclusion and restraints, but it trains them on recognizing the warning signs of an escalating behavior, verbal and nonverbal de-escalation techniques to prevent behaviors from progressing, identifying triggers that cause a student to act out, last resort methods for intervening physically with as little potential for harm as possible, recognizing signs of distress, documenting incidents, establishing and reestablishing a strong and supportive relationships with students. You do not want a student to fear you every time they see you when all you're trying to do is help them. CPI's top 10 de-escalation tips are to be empathetic and non-judgmental, and not to judge or dismiss the feelings of the person in distress. Respect their personal space and be aware of your position, posture, and proximity when interacting with the person in distress. Use non-threatening nonverbals by keeping your body tone and body language neutral. Keeping your emotional brain in check by remaining calm, rational, and professional. Focus on their feelings. Ignore challenging questions. Set limits. As a person progresses through a crisis, give them respectful, simple, and reasonable limits. Be clear, speak simply, and offer positive choice first. Choose wisely what you insist upon. It's important to be thoughtful in deciding which rules are negotiable and which are not. Allow silence for reflection and allow time for decisions. There were 17 other training programs that were found to help train staff on de-escalation techniques. Those are Calm Every Storm, Management of Aggressive Behaviors, Nonviolent Crisis Intervention Program, the Oregon Intervention System, PMT, PROACT, Professional Crisis Management, Response, Right Response, Safe and Positive Approaches, Safe Crisis Management, Safe Prevention Principles and Techniques, Safety Care, Satori Alternatives to Managing Aggression, the MANT System, Therapeutic Aggression Control Techniques, Therapeutic Crisis Intervention. The average allocation across those training programs are crisis de-escalation, restraint procedures, general information, debriefing and follow-up, dangers and risks, monitoring procedures, seclusion, and the other 11% would be protection techniques, mental health, and trauma. The overall goals of de-escalation techniques are to communicate, respect, and promote dignity, to reverse the momentary escalation and intensity of crisis behaviors, teach and strengthen behaviors that are incompatible with crisis behaviors, safety and therapeutically manage crises without injury or trauma, terminate crises as quickly as possible, reduce the future likelihood of behavior crises, restraint prevention and elimination. Knowing good de-escalation techniques can be a good way to prevent the use of seclusion or restraints being used. Without the proper training, one may not know how to properly de-escalate a situation and automatically use what they know, which could be the use of seclusion or restraints. All schools and agencies should have mandatory training at least 3 to 4 times a year on de-escalation techniques and how to properly use them. Nobody wants to have to use them, and since not everyone has to use them all the time, it's good to get that refresher to make sure no laws have changed, get notified on any changes or updates that have been added, and make sure that you have not forgotten anything you've learned in the past. A well-trained staff will be better at preventing injury or breaking any laws. Now Brooke will be talking about the against side.
While there are some very compelling arguments that can be made for the use of restraint and seclusion in individuals with autism and other developmental disabilities, I believe that the bad strongly outweigh the good. The biggest issue lies with the ethical treatment of the patients. The BACB Code of Ethics states in Code 4.09 that behavior analysts review and appraise the restrictiveness of procedures and always recommend the least restrictive procedures likely to be effective. Restraint is a last resort because of the effects it has on not only the clients, but also the caregivers who must be included in this restraint process. First, we'll discuss the effects restraint and seclusion can have on the patient or client. The main ethical concern we face when discussing restraint and seclusion is the violation of personal freedom and dignity. One of our top priorities as professionals in ABA is client integrity. We must keep that at the front of our minds every minute that we do our jobs. By restraining and secluding individuals, we risk maintaining that client's integrity and respect. In addition, some individuals with autism have a tendency to be made uncomfortable by the touch of another person. If an individual goes into a behavior and is then restrained, it can put even more stress on the situation and not only escalate the intensity of the behavior, but also put the individual and the caregiver at a higher risk for injury. The risk of injury is already high when a caregiver is restraining someone due to lack of training or experience, but if the behavior of the individual escalates, this can put everyone involved at a very serious risk of injury. In terms of seclusion, our job as professionals in the field of ABA is to help our clients cope with their behavior and find alternative ways to behave. By secluding these individuals when they are having a behavior, we are not doing our job to help them. Seclusion can also intensify these behaviors and make them more difficult to understand and overcome. Restraint and seclusion can also cause serious psychological trauma for the client. It can bring back past memories of abuse that the individual may have faced and can set them back even further. Now we'll discuss the effects that restraint and seclusion can have on the caregiver. Just like with the client, being a part of an individual's restraint can have a huge psychological impact on them. Studies have shown that many caregivers who were required to restrain an individual express feelings of guilt and self-condemnation. Not only can it harm them psychologically, the physical harm that can be caused by restraint is also quite concerning. Even with proper training, restraint can be very risky. Restraint can cause a client to become more aggressive and lash out against their caregiver, or the restraint could be done improperly and could cause unintentional harm. According to a study of emergency restraints, 1 in 3 restraints resulted in an injury. And these statistics are involves binding the wrists and ankles and attaching all 4 extremities securely to the back, as you would a hog. The cause of death of these individuals who were restrained is extreme agitation or excited delirium. This means that after being restrained, heart or breathing can stop. This is not a way to treat them in our care. There are alternatives to restraint and seclusion that we should be using instead of these violent and demeaning ways. The first is focusing on the preventative care of the individual and keeping them from getting to a point where they may behave in a way that could call for restraint. For some individuals, this could include maintaining a regular schedule and reducing circumstances that could lead to aggressive behaviors. Sometimes the medication that an individual is taking can have side effects that can increase aggressive behavior. Being aware of these side effects and keeping an eye on them can help reduce the need for restraint as well. Another proactive strategy to reduce the need for restraint is called restraint fading. This method helps to manage self-injurious behaviors before they get to a point of requiring restraint procedures. For example, an individual who exhibits hand-mouthing may wear an arm sleeve to prevent further self-injury. This keeps the client's dignity intact and keeps the individual safe. Overall, a better understanding of clients' needs and behaviors can keep caregivers alert and prepared for the precursors of aggressive or self-injurious behavior. To conclude, there are many alternatives to seclusion and restraint that have proven to be very effective, that there is no need to risk the lives, integrity, and safety of our clients and staff. And now we'll move on to some question and answer.
Thank you guys for all the information that you've been able to gather and present to us. Lisa, we appreciate you being able to go ahead and discuss the strategies and methods to help improve the training for administrating restraints and or decrease the need for restraints. Now, as far as the use of restraint and seclusions from setting to setting, for example, in Indiana, mechanical restraints are not recommended to be used for people in adult services. Is it ethical to use this as a way to address behavior if it's not something that can be used across various settings? What can happen to a child if a child has a mechanical restraint in one setting, but then moves to a new setting where that type of restraint is not allowed?
In my opinion, I believe that it is not ethical to use these types of restraints that aren't allowed in all states or all circumstances, because if that child was to move to a different state where those restraints were allowed, it could be even more traumatic and even more dangerous. And that could be at a higher risk of injury.
Thank you for that, Brooke. Now, Joey, have you ever had any kind of personal experience related to the topic that you would like to share?
In my profession, I'm a school psychologist, and I work at a couple of elementary schools. So just throughout my time there, this is my 9th year being in that role, I've been in several situations where we've needed to utilize seclusion restraints. We felt as a team it was the last resort in those situations, just due to the aggressive behavior of the child. For example, they were running out of the building across in the traffic, or being very aggressive towards other staff or other children. So, and in the schools I work, we do have seclusion rooms that we do utilize when needed to help manage students' behaviors. They're not used much, but in those last resort situations, we do use them as opposed to restraints to reduce the risk of injury due to restraint. So I work in Wisconsin, so there is our laws kind of governing what schools can do with seclusion and restraint. So in Wisconsin, we have Act 125 that went into effect on September 1st in 2012. So the act applies to both regular education and special education students and prohibits seclusion and restraint except when certain conditions apply. So what the state said is seclusion and or physical restraint may be used only when a student's behavior presents a clear, present, and imminent risk to the physical safety of the student or others, and it is the last restrictive intervention feasible. Certain maneuvers and techniques are prohibited, so chemical and mechanical strains are not to be used in schools at all, or at least in Wisconsin. Seclusion rooms may not have locks, and rooms must be free of any object or fixtures that may injure the student. In 2019, Act 125 was updated, which is now Wisconsin Act 118. So it expanded on Act 125, some of the laws. So some of the changes are it now requires parents to be provided with a written copy of the incident. It requires staff to hold a meeting after each incident of seclusion and restraint to discuss topics specified. with that student, and they need to conduct an IAP team meeting within 10 school days of the second time seclusion or restraint is used on a student with a disability within the same school year. So that's kind of the gist of my experience. And I guess that so in Wisconsin, or the schools that I work, I will say that we have gone through training. So it was one of the training that Lisa kind of went through, CPI. So I've been trained in that. I've done the initial and several refresher trainings, and all other staff that typically help manage those severe behaviors in the schools I work do go through that training as well.
Okay, awesome. Thank you guys all for your time today and sharing your experiences and your researches on the use of seclusion and or restraints.